Okay.
We are recording. So, welcome to the inaugural very first Hat Talk podcast. The Hat Talks exist to discuss with healthcare thought leaders in order to provoke ongoing debate and encourage greater personal connections, spanning the medical, scientific, drug development, and strength and conditioning areas. Today's guest, our very first guest, is Dr. Peter Polos, who is a pulmonary critical care physician. He's affiliated with the Hackensaw JFK Medical Center in Edison, New Jersey, and the Summit Medical Group, Summit, New Jersey.
Thank you so much, Peter, for being on.
Yeah, thank you.
Thank you all for inviting me. I'm happy to be the kickoff guest for this rather unique way of gathering people's attention to discuss, as you said, science, drug development, and medicine. Great idea, and I'm happy to be a part of it.
Wonderful, thank you. Happy to have you. So you have been in the front line, in the ICU rooms, helping patients, COVID patients, for over the last several months. Can you just give us an overview of what that's been like, and I guess starting with the basics, what is going on with this pandemic?
So, if we back up to around March, when this really started to hit, from when the first case in the U.S. presented to the rapid explosion after that, the institutions I'm affiliated with were overwhelmed, not to the point where if you had maybe 3 ICUs in your hospital, you suddenly had 5 or 6 or 7 ICUs. They were grabbing every free space they could to treat these patients that were just pouring through the door. It was very intense, and no matter, I think, how much training you had as pulmonary critical care doc, this is something we never obviously ever experienced. Just the volume, the mortality rate, the severity that the patients came in with, and the rapidity with which they decompensated almost in front of your eyes, quite dramatic. Happily, we're now sort of on the other side of that in most of the institutions, and the ones I'm affiliated with and colleagues of mine, where we are still quite busy, but much better. I told someone the other day, the irony is that now we have maybe 1/3 in one of the institutions I'm at, 1/3 of our ICU beds are ventilator beds. That's a big number. But it's so much better than it was before. It doesn't seem so bad. We're still getting patients. Obviously, if you look at the heat map in the United States, the Northeast, where I am in New Jersey, New York, Connecticut, Massachusetts, Maine, etc., their numbers are down. I think that region of the country, despite its population, responded very well to the recommendations of lockdown, of mask and distancing and hand washing. And I think the proof is in the results here that, we are a much cooler spot in the country than other places. We're now starting to ramp up and perhaps go through what we went through in the Northeast, maybe not to the same absolute numbers, but the same relative sort of stress to that healthcare system.
Right. That's interesting. I've heard it compared to the way the Northeast responded to this was almost mimicking the way that Europe did. And when you think about that population density, that's pretty impressive for the Northeast when you're in New York, New Jersey, and all those bigger areas. And now we're seeing, as of last week, a lot of the peaks that we're getting are in some other states. Chris had shared with us, there was Texas, Arizona, Utah, Florida, Georgia, North Carolina, South Carolina, Arkansas, Tennessee. Some of those, I guess, less densely populated areas are seeing spikes now, and they're also some of the ones with the beaches. And as things kind of lift up a little bit, we're seeing some more spikes, especially Chris and I are both here in North Carolina, where there's quite a few cases right now too.
That's right. And I think the irony is that right now, if you are looking to go away for summer vacation, the Northeast, ironically, is the best place to go.
Nobody ever says that.
In terms of prevalence of infection, etc. I think running to the south right now is not a good idea, given what's going on. And I think that's evidenced by the fact that the state's opened. And the problem with all of this is sometimes we dance very close to the line between politics and medicine. And it's very easy sometimes to jump over that line and distract the discussion. So I cautiously tread on that when I say I think proper leadership in the Northeast and people adhering to the leadership showed good results. That's not to imply that there's lousy leadership elsewhere, because then we've crossed that politics line again. Yeah. I'm just saying I think strong leaders in the Northeast, people adhere to that, and I'm hopeful that regions that are hot again now will see the results of what they didn't do and start to do it now. And it doesn't really matter who was in charge at the time, just follow the rules.
Yeah, I think that's a very valid point that you bring up, the cross between politics and medicine, because, you know, like in North Carolina, we continue to see the spike go up. I mean, we're not flattening that curve at all, but we did implement the same rules as they did in the Northeast. We're just not following those rules. I mean, we have a Coalition to Reopen North Carolina group that is basically burning masks and trying to get everybody else to do the same. And that's what's causing this spike on our end, and this continued, you know, increase in numbers on our end is because people aren't following those rules. So, and they're claiming First Amendment rights infringement and things like that. Where to me, it's just basic common sense. You know, just we're not telling you to put a mask on so you can't breathe. We're telling you to put a mask on so that you're not transmitting this, they're not being transmitted to you. Same thing with hand washing and things like that. And I do see where a lot of those lines have crossed between medicine and politics, which is causing some of this turmoil and definitely increase in rates.
Absolutely. And at the end of the day, the only way, I mean, as you know, it's trite to say the virus is not political, but that's true. Okay. The virus really doesn't care where you line up to vote, who you are, where you live. The virus is the virus. And, you know, if we can finally just not make things like masks political and distancing political, we'll get on top of this. But obviously we haven't done it yet. And, you know, I'm of the opinion, and it's not just me, many of us who follow this very closely, as I do, you know, everybody's talking about the second wave. We haven't gotten past the first wave yet.
It's really
I agree with that.
How much of the situation in Europe is reported in the US? Because we're in a situation now where we are in the UK, here in the UK, seeing various lockdown measures taken down, and it's very much. I mean, the big issue for me as someone who is kind of integrally part of CrossFit and small class-based gymnasium systems, it's one of the businesses that isn't allowed to open, and yet the UK's just relaxed the distancing and lockdown laws and rules for the hospitality sector. So the big thing at the moment is that, you know, the pubs and McDonald's are open, but a small controlled environment where social distancing measures are possible, and there's you know, who's coming in and out is perfectly understood and known and tracked, and arguably has positive impacts on health economics, isn't open. So we're in a situation where a lot of the logic behind some of the lockdown easing of restrictions is very economy based, rather than, and it just doesn't feel logically like the situation where we can now be 1 meter apart and we can exercise outside with people from 3 or 6 people from other households, as long as you're distant, right? But we've always been able to exercise as long as you're distant and you can cross paths in a local park with people from more than 6 people. So the logic behind some of the easing of restrictions just doesn't make a lot of sense to a lot of people. But that said, the UK is probably about 4 weeks behind places like Italy and France and Spain, and they are seeing second wave spikes coming through now. So it's kind of a really interesting situation. And from my point of view, listening to you talk about the US not having been through its end of its first wave yet, I'm just curious to know, I mean, how much influence does what's happening in Europe, how much does that taken into the situation in the US?
I don't think enough. I think the the spikes that we've seen and are continuing to see depends who you talk to. I don't think they're being acknowledged enough in the United States, and that's why we're in the problem that we're in. We should look now and see. Let's look at Italy for a minute. I know we want to talk about COVID, and we should, but let's just go one more minute on this. I don't want to. It's your meeting, Darby, but let's talk a little bit about Italy, for example. So remember when this first hit, Italy was decimated. I mean, that was the news, right? We thought, all of Italy was going to die. It was horrible news. Mostly northern Italy at the time, right? Now, if we know anything about Italy, and most of us on this call have interacted with Italy at work and jobs and things, it's a very fragmented country in terms of politics and regional differences. And southern Italy, Sicily wants nothing to do with Milan and northern Italy. They view each other quite differently, right? And they have a very fragmented government. And yet what they did is they took, which was something that was essentially a northern Italy issue, COVID deaths, and they made it across the board, countrywide lockdown. And to their credit, all those fractioned groups that normally say no just for the sake of saying no fell in line. And that's why Italy's numbers came down so quickly. That was the argument a lot of people gave for the United States, that in the beginning, what we should have done, and this is not armchair quarterbacking, there were many people at the time saying it, is we should have shut the entire country down, 100% lockdown, 2 weeks, 3 weeks, I don't have the range, but I mean, a total lockdown. Take the major economic hit, suppress the virus, and then come back. But if you look, we never really did that. Every state had their own thing. We even had that in New York, and New York was pretty good, New Jersey was very good. But even in New Jersey, well, you can go out for essential shopping, you can exercise with 2 people, like you were saying, Edward, sort of bizarre things. So it was sort of every state. In fact, my daughters would ask me, so what's our lockdown? Why is it different than Connecticut's? Because it is. And because of that, I mean, at least the Northeast responded, but I think that's what was going on in places like Arizona and in the Southeast, et cetera, as opposed to a blanket lockdown, one major economic hit. Instead, we were doing this sort of piecemeal whack-a-mole thing. We've had 3 stimulus packages, might need a 4th, and we're not out of the woods yet. I know we're a bigger country, but that one can argue maybe we should have done that. That's history now. What we need to do, like Chris was saying, I was saying earlier, is follow the rules. It's not that hard. Mm-hmm. They're simple rules.
Completely agree.
Simple rules.
Yeah, I think that what we've heard from some friends, colleagues in Europe, what we've seen is not only the duration, but the, I guess, implications that would be faced if you were to go out in public. Europe handled it in a completely different way, and with togetherness as a team than I think what the U.S. did. And that kind of what you said, it goes kind of state by state. And, how serious is this? It's been very different. I mean, some cities in the U.S., 2 weeks was their lockdown. And, you can be asymptomatic, but it's 2 to 14 days before usually you show symptoms anyway. You might have it for that long. So if everybody were to just kind of hunker down together, got on the same page, it could have been, greatly controlled compared to what it is now, which brings us into, what about this virus? You have some information on like the viral load, how it spreads. Do you want to share some of that? And then we'll go into some of the chest x-rays that you have.
Yeah, sure. I'll talk a little about the clinical. So these patients initially this is an area that we are almost daily learning something new about, okay? So where we are now in terms of our knowledge of the virus and how the patients present is quite different than it was in March. But so I'll take you back to March a minute and let you know what we were seeing. We're, of course, obviously predominantly elderly population, although we were seeing occasionally 30s and 40-year-olds, 50-year-olds, but generally elderly, who were coming in with symptoms of the usual with fever, shortness of breath, profound hypoxemia. And what was interesting with some of the hypoxemia in these patients was that despite very impressive hypoxemia levels, and I mean that in a negative way, like patients who were profoundly hypoxemic, they were remarkably asymptomatic to some degree. In fact, it was tagged silent hypoxemia by some, because typically if you have a low blood oxygen, you are sort of starving for oxygen, okay? And you're reacting that way. These patients were coming in somewhat short of breath, but almost disproportionate to the severity, suggesting that perhaps this had been ongoing for some time and there was an adaptation by the body to the drop in oxygen so that it wasn't a profound acute event. That's one theory. Patients came in, they had fevers, often, sometimes not on presentation. Sometimes the fever was one of the last symptoms to present. We also knew we had the reports coming out, subsequent rollouts of loss of sense of smell and taste. The theory for one of the explanations for that potentially is that there's receptors on those neurons in the nose that the virus can attach to, and that their attachment to those neurons might affect the function of those neurons, one theory. So the patients came in and we were looking at them, getting their blood gases, getting their chest x-rays, and they were looking, they had a phenomenon called acute respiratory distress syndrome, or ARDS, which is defined as profound hypoxemia. There's numbers for that, but severe hypoxemia, an abnormal chest x-ray without a cardiac etiology. So if you want to throw a couple of those x-ray films up, I'll explain. And I'll tell you, these are from COVID patients, but these could be any ARDS patient, okay? This is classic ARDS radiograph, but in the setting of someone with this hypoxemia who's COVID positive, it's a COVID ARDS as opposed to a bacterial ARDS. So for those who have not seen, this is a normal chest x-ray, and as you're looking at this, the image on your left is a frontal view of a patient, and all chest x-rays should be presented as if the patient is facing you. So your left side is that patient's right side, okay? In the middle, that blob hanging there, that's your heart. And then on the right-hand side of the graph, of the picture, is the lateral view of the chest x-ray. And that white dome that you see on the bottom in both of those, that's your diaphragm. And the rest of the film, where there's black, there's air, okay? So that's an aerated normal lung, okay? These now are a series of images of a patient who came in with coronavirus, and you can sort of see, even just having seen one normal film, that the first image on the left is not normal. You see fluffy balls, it looks like, infiltrates in both lungs. And as you go left to right, you can see the progression of those infiltrates as they advance through the lung. And so you can imagine, as I said, black is air, you're seeing less black, right? So it's difficult to oxygenate and difficult to ventilate in a patient who's had their normal lung tissue overwhelmed like this. I think there's another one as well. Mm-hmm. Same here, image left. You see on the right, the patient's right lung, which is on your left. Over there by the collarbone, you'll see kind of a dense infiltrate by the shoulder area. You can see down at the bases. That diaphragm that we talked about is almost obscured here because there's infiltrate, or there's infiltrate that's infection in the lung, and it's in both lungs here. And similarly on the right, these are infiltrates, bilateral infiltrates. So when you have that sort of radiographic picture, when you have the increased need for oxygen, or said better, the profoundly low oxygenation despite high administration of oxygen, and in the right setting here of COVID, this is COVID or coronavirus, ARDS. So this is what we're seeing. So then I think that's it on, this is some CAT scans. Yeah, what the heck? Let's do some CAT scans. So this is a CAT scan, and this is kind of cool because a CAT scan gives much more detail, of course. CAT scans are typically done with the patient laying on their back, and you're viewing this as if you're at the patient's feet, just to orient you, okay? So if you look going at the top left, that sort of black hole right in the middle, that's your trachea. So that's to orient you. So the right lung is on your left, the left lung is on your right, and you can see the spine right down in the middle, you know, that kind of spiculated shaped object. And so this is a normal CAT scan patient. The heart is in the middle. That's a big globular structure as you go through the images, top to bottom, left to right. The next one, I believe, is an abnormal CAT scan. Yep, abnormal CAT scan. So here in picture A is how the patient first presented. And then as you can see here, as we march through B, C, D, and E, the progression of the disease on the CAT scan of this individual. And again, you don't need to be a radiologist to realize that you know, D is a lot worse than A, okay? So this is what it looks like on imaging.
Thank you for sharing those with us. It's very interesting.
Sure, thank you. So what we did is we used to intubate these patients right away, put them right on ventilators, and then there was some data that started to show that maybe perhaps you can buy some time by using alternative ways to oxygenate patients, either to avoid intubation or to buy time until you had ventilators that are freed up, because ventilators were at such a premium. And sometimes you had to wait to get the ventilator if someone was discharged or passed away and free up a ventilator. So there were, we started to look at alternative ways to oxygenate these patients. And then for treatment, initially there was nothing. I mean, there was nothing. There still really isn't much at all. We know that now. We looked at hydroxychloroquine, no data ever to support that. In fact, maybe more damage than not, but certainly not a positive. We also know that antivirals were looked at. We know that there's going to be one now for standard of care, probably will be for standard of care. Steroids were looked at. There was a recent dexamethasone study that showed some benefit to steroids. And let me take a second on that, because everybody got all worked up about steroids and ARDS. Nothing new there. Okay, we've been giving steroids for ARDS for years. What there is controversy as to whether it actually makes a difference and when do you give it. Do you give it early on in ARDS or do you give it later on in ARDS? So this is nothing new. It's in fact part of standard of care. I haven't seen that all the data on that study. It hasn't been published yet. I think that was sort of a pre-release, right?
That's the recovery trial, I think. And
right.
I mean, it was reported here a couple of days ago. So I can't remember the exact numbers, but there was something like a 20% or a 30% improvement in outcome on both ventilated and so the severe and the moderate disease presentations as well. So it's interesting how it was. Obviously the media here is the media, and it was spun as a go Britain, we're leading the world on at the forefront of treating COVID. It's like, yeah, but it's a
they show 28%, right? The biggest improvement was in the most severe patients, the ventilated patients. The next biggest improvement were in patients that were on high flow supplemental oxygen, and the least improvement was in the least severe patient. And it showed some. I haven't seen the data though, so again, it was press release data that seemed to show that there is some improvement or response in the severe patients. We have to look at the data to really be sure. There may, in the end of the day, be really nothing new there that we didn't already know.
No.
And we're given steroids to these patients at the end stage anyway. The question has always been, do you give it early to prevent the inflammatory process, or do you give it later to dampen it down? Well, that's always been a controversy with ARDS.
Interesting.
So speaking of treatment, oh, go ahead, Edward.
So what's the
whatever.
I just wanted to explore that controversy a little bit about the steroids and ARDS. I think it might be interesting for people just to understand a bit more about why the dilemma on the inflammatory response, whether you give it early or later. What can you say on that, Peter? Is that something that's worth just mentioning?
Yeah, so that's the controversy. So there are those who are in the early camp who feel if you give it early on, you can prevent some of the consequences of ARDS, which is scarring and fibrosis in the lung. But the people who feel it's better off later feel that if you give it early, you might dampen or suppress the immune response by the patient to whatever is the inciting cause of the ARDS, and you may be working against yourself. So better to give it later when everything else you have been doing hasn't really been working, and you gave the immune system its chance to work through, you've done that, and then perhaps a corticosteroid later on will help either suppress maybe a cytokine storm that could be going on or something else. So it's two different camps approach. I'm more of the early camp. That's because that's how I was trained, but that doesn't make it right, because some of these studies are very difficult to do and to interpret. That's why the dexamethasone study, need to see the data before we go and say conclusively all patients who are severe on a ventilator should be given dex. Not sure yet.
Well, that also brings us on to one of the, well, we just answered one of the questions that we had anyway, but kind of brings it into another one, which was, I've seen some comment about what the economics of having a kind of a long-term implication of that severe population group. So we end up with a high number of people who are presenting with pulmonary fibrosis downstream. So we end up with all of these severe patients are going to have downstream issues with the fibrosis at a later point in time. And I'm just curious, is that something that we should be factoring in to look at now, or is it a question of, we're having to deal with the existing treatments so much that that's just something to worry about at another time?
So, I hate to say this, but we don't know, Edward. First of all, we don't know what the long-term consequences of this viral infection is going to be on the patients who survive. Not every patient who survives ARDS, even before COVID, develops fibrosis, which is, again, was the later rather than earlier camp. Why give something if they may not develop it anyway? So again, I think that that's an unsettled issue. We don't know what the long-term complications are going to be. Will it be damage to the airway? Will it be damage to the lung parenchyma? Will it be damage to both? Don't know. Can't say. So
who's going to do that? Who's going to do that research though? I mean, everybody seems to be focused on vaccine or symptomatic treatment now for COVID, but who's going to be putting in the structures in place to do that long-term research for?
Well, I think if anybody's interested first, I mean, you have to determine that there's a reason to want to do it. And I would think that probably if you were going to do it, it's a kind of a prospective study. You follow patients who survived COVID, and you'll follow them long-term, and you do lung function, and you do radiographic imaging, and you look at them clinically and see over, a 3 to 5 year period, do they return to whatever their baseline was before? Which is also an issue because some of these patients already had pre-existing lung disease to begin with, which put them in the high-risk group. So they may never get back to their baseline, but that's also not uncommon in ARDS for patients who have pre-existing lung disease to start with. So my guess is if you're going to do it, it's kind of a prospective study, and then you can interpret that however you want.
Peter, there's a lot of people out there that are comparing this to flu, basically, saying that a year or two down the road, we're going to look at this in hindsight, and it's going to be, oh, we have a vaccine for it like we do flu, or we have, a treatment methodology in place like we do flu. What do you say to those people that compare that to flu? And are they right thinking that if we get vaccinated later on down the road that we don't have to worry about this?
All right, so number one, this is not influenza. Number two, This is not influenza, okay? That's critical. Having a vaccine, we'll get to in a minute, is another issue. But to start to link in any way, simply because we might have a vaccine, to try and link it to influenza diminishes the impact that this virus has now and will have until we have that vaccine. I've seen many people online say, oh, it's nothing more than the flu. We've had some leaders say it's nothing more than the flu.
Right.
And by now, when you have 23,000 deaths or something, if you still want to call this the flu, you know, you're really missing the boat.
I
this is more.
I think there's a lot of confusion between mortality rates, incidence, and the epidemiology of the virus. As my understanding is that there is no successful vaccine development for either of the prior two coronaviruses that we've seen through SARS and MERS, even though that's been worked on since those outbreaks happened. And the idea was to build it into the seasonal flu vaccine, so it was a single shot influenza and coronavirus vaccine. But that's not actually come through yet. So I listened on one hand to the likes of Anthony Fauci and the British Scientific Advisory Board. They're saying, yeah, there's going to be a vaccine by the end of the year. And I look at it and from the drug development perspective, yeah, right. But then secondly, you know, on the other side, you look at our track record of vaccine research for the prior two coronavirus outbreaks, and it's not been successful. And what was the last one? Was 5 years ago? So it's just kind of, you know, from that's all kind of swirling around in my head as well at the moment. It's just.
Sure. So let me try and address that. This is not the flu. Again, I think that's very important. Okay, the flu is here. The flu will always be here. It's an avian virus. Okay, flu will always be here. We try and make our flu vaccine in anticipation of the H1N1. These are the primary markers on the virus of what we expect it to be next year. We make the vaccine this year. Sometimes we get it right on, sometimes we miss it completely, and then there's everything in between, okay? Because it's predictive. This virus is highly contagious. This virus is in a family of viruses called coronaviruses, which we have all had in our lives. There are many common cold viruses that are corona family viruses, okay? But remember back in the beginning when this thing hit, we were calling this the novel coronavirus. Why was it novel? Because we had never seen this before. This wasn't like the previous coronaviruses. Now, things like SARS and MERS were interesting. They never panned out as we thought they were going to in terms of pandemics. And there are a lot of reasons for that. For example, SARS is much easier to control. All right, you are not contagious until you have symptoms with SARS. You are not contagious until you start having bleeding and coughing and GI and bleeding from the airway and nose. Until then, you are not contagious. So you can isolate those people easier and contain the virus. This virus, as we all know, you can be asymptomatic and it's transferred by a respiratory mechanism. Not direct contact like HIV, not SARS where you are infectious and you still have to have contact with a patient who's clearly ill, okay? The other thing about those vaccines, Edward, is the two leading candidates for those, particularly SARS, there were funding issues. They were well along and funding stopped when it turned out not to be the pandemic or the epidemic that everybody thought it was going to be, okay? So it was like, nice job, you go, oh, it's not as bad as we thought, funding stopped. That's bad. The upside to that is so much was learned from those programs to develop the vaccine that those are being applied to the development of this vaccine. So I think the traditional 10-year window to develop a vaccine, which in this country has been about 10 years from start to launch, certainly was shortened with SARS and MERS in terms of getting things up and going. And for COVID has been shortened to under 2 months, which is amazing. But that's in part built on a few things. The previous data for the SARS and MERS, which went nowhere, but we learned from that. From the fact that this is now not just an African disease or a Middle East disease, as those were. This is a global disease. And when you got the big 5 and the big 7 involved in here, and economics come in, suddenly everybody decides, well, we're going to fund this and get this going. Which is why in the UK, Oxford's got the leading candidate there, and then Morona, and then we have here in the US a couple. So there's a lot of private and money being pumped into this around the world. The thing is, the window will be shortened because, okay, traditionally we made vaccines one of 2 ways. You either had attenuated virus, that is an inactivated virus like polio, or you made a vaccine where you used an antigen from the agent, like we do for whooping cough, for example, or hepatitis, okay? All of those have to be grown in a culture environment. They take time. The first one is typically in eggs. Hepatitis is in yeast, but they take time. What they're trying to do now is in these RNA viruses and batch grow them, where they actually take the RNA and inject it to stimulate the cells to make the antigen that the body recognizes as foreign, so that when the virus comes along, it's armed and ready to go. That's what shortened it a lot. The question's going to be, to me, the bigger question, because to me that was never a question of being able to do it. It was always, well, how quickly can they do it? Having it, then doing your preliminary testing, volunteer testing, is all well and good. But as I tell everybody, quite a difference between having a vaccine and having the global capacity to vaccinate.
Yeah, I mean,
that's the challenge.
Yeah. It's really interesting because the Oxford vaccine is, I mean, a lot of that research has come out of the Jenner Institute. There's a company called Vacutech who are a spin out from the Jenner Institute, where the technology originates for the RNA vaccine. And they've also partnered with AstraZeneca and a number of other companies around the UK for the manufacturing capacity. So it's a really interesting collaborative effort, which kind of, it's going to be interesting to see what happens in terms of the commercial and the political realities once we're doing the right thing for mankind. Goodwill starts to run thin as this gets kind of further and further through the teeth. It's going to be interesting to see how the kind of licensing and collaboration and the commercial realities of how our business works actually starts to play on it. And I sincerely hope that it actually doesn't impact anything, but it's going to be really interesting to see what happens, I think.
It is. I think, remember, this is not like developing a drug to treat a disease, right? Yeah. You have a disease, we have a drug, we give you the drug. This is developing a vaccine to give to somebody so that they don't get the disease, and then do the study and wait and see if they get the disease.
Yeah.
Right.
Okay. So there's your huge window there. And it's estimated, I mean, these are multiple models. You can find them easily, search them up. But numerous models that say if we really wanted to get rid of this globally, and I'm not talking about politically or economically, because clearly, just like HIV, we think HIV is gone. It's not.
No.
You go to Africa, you go to the Middle East, it's not gone. But again, those are not the big 5, big 7 regions of the world. Nonetheless, it's estimated that about 60% of the world's population, which is what? Is it 8 billion? Sound about right? 60% of the world's population would need to be vaccinated or had been exposed to the virus with antibodies and survive to have enough herd immunity that the virus essentially would be gone within the world, okay? You might have one here, one there, but it would dissipate out over time. So you're looking at maybe 5 billion people, okay? We make vaccines at hundreds of thousands of doses.
Right. Peter,
Sorry, world population as at end of March was estimated to be 8 billion.
Okay, so if 60% of 8 billion, it's 5 billion people, right? And we make vaccines at hundreds of thousands, maybe we make millions here for the US, but we're talking staggering numbers if we want to attack this globally. Because remember, we are not on an island here. We can get us under control, but the EU, Latin America, Middle East, Asia, if they have it there, and we're all immune here, that's really nice, but that's really not the way the world should run. This is a global issue.
Well, it's part of your presentation, Peter, that you had shared with us before. You talked about the last pandemic being the Spanish flu in 1918, and we pretty much don't see that anymore. What's the difference? What did we do differently then?
Okay, so for the record, and I'm not crossing the medical political line here, but let me give you a little historical. Okay, the Spanish flu did not originate in Spain. Okay, and there's some people who are using that as an explanation to call this the China virus. Okay, the Spanish flu originated in Kansas at an army base just before World War I. And when our troops went over to Europe, it spread. World War I, Spain was neutral. Spain wasn't involved in World War I. Spain's press, because they were neutral, was taking pot shots at everybody in the world, causing this war. They were taking their radical political stance because they had no vested interest, so they could go after anybody they wanted to. They had no side. So it became politically expedient to say the Spaniards caused this because they were felt by the countries involved in the war that they were exacerbating the issues around the war. So it was a scapegoat. Spain, oh look what Spain did. Spain's infecting everybody, Spain everything. Check it out, did not originate in Spain. So let's clear that, okay? We call it the Spanish flu, that's a misnomer. I'm sorry people keep doing that. What happened with that pretty much is people died. People died. Some people survived. There was herd immunity and death. And that's why. And we could ride this one out and go the same way. We could stop all vaccination, we could stop all development programs, and we can see who naturally survives this and who doesn't survive it, and it'll eventually go away. But obviously we don't do that. This is, remember, also 1918, people were not flying around the world. People didn't have cars to drive from Florida to New York or New York to Florida, or from France to Germany. So it's a totally different world situation. So those are the reasons why that went away. And those are the very reasons why we will have another pandemic. Maybe not in our lifetime, maybe our children's lifetime, maybe it will be another 100 years. I don't know. You can argue it would be less because of the way the world, not only the world is much smaller, the environments for these viruses, which are typically zoonotic, avian, swine, those hot spots, most of those coming from open markets in Asia, those environments still exist. And until culturally those can be cleaned out and weeded out, the potential for this to happen again is there. And the big worry was always the next flu pandemic. Well, then Corona came along and knocked that off. And now that doesn't mean we won't have another one. That doesn't mean we won't have a flu pandemic. They're unrelated. Learn from this.
I was going to say, Peter, I was told in 1996 that we were 30 years overdue for the next flu pandemic. That was 20 years ago, well, 20 plus years ago. So, it's been interesting. I was digging out all my old microbiology notes just to try and prep myself back up on it. But it's interesting thinking that, it's a lot of people were saying, the kind of why now? And so, well, technically, according to incidents in history, we've been overdue for a long time. So,
been overdue, which is what makes me think there will be others, and there may not be this level. There may be more epidemics, big major epidemics, but we have to learn from this in terms of preparedness. We have to learn from this to not make this political, and we have to learn from this to work together. We got rid of smallpox, right? There's no smallpox left in the world. That was the major killer. That was the reason the French walked away from the Panama Canal. Otherwise, that would have been French-owned. They were losing 50, 100 guys a day to yellow fever, to smallpox, all of these. And that took concerted efforts by countries, particularly smallpox. That was a decision between Russia and the United States to hold hands on that and collaborate and rid the world of that. This pandemic is going to take the same sort of effort. The next pandemic, we should be ready for and roll out the same sort of, working relationship, PPEs, supplies, and not be late to the party. In the United States, we were always playing catch up with this virus. Always. We were never, ever ahead of it.
Mm-hmm. So it's interesting what you say about herd immunity. I've heard that some states are a little afraid of, there is and has been for quite some time some anti-vax movement. So if we did find something soon, I think everybody's hopeful that we can create this herd immunity. And we won't go there because that's a whole other thing to open up. But I've already heard this as a concern. But I just wanted to say, we have pulled some information from something called Trial Trove, is a tool that we utilize. And there's over 2,200 clinical trials going on right now for COVID, and over 1,200 of them being treatment, and around 700 of them for novel coronavirus pneumonia. And it kind of, goes down to asymptomatic COVID, healthy subjects, vaccines, 132 vaccines. So it's really interesting the amount of work that's going on, and this is worldwide, across all phases. And it'll be interesting to see with the fast tracking that everybody's doing and the different collaborations, what will come in the future, and definitely, hopefully, we'll find something sooner or later.
So I think right now, anybody who has a compound or an idea that has a whiff of potential use in COVID are trying to get in that line. And the FDA is going to have to do their decisions on fast tracking. I know that they're looking at a lot more adaptive clinical design trials. I know that I think compounds that have a pre-established safety profile may have a little bit more of a leg up than new compounds that have to go through all of that, both in terms of time and both in terms of workload on the system. But you're right, over 2,000 of them. This is unprecedented. Some of them will fall aside, but that's good news. And just to back up to your point, and again, this is not the political line, but the anti-vaxxers, this is very curious. I'm curious to see the people who've been against flu vaccine and childhood vaccines and all of this. When and if we have a COVID vaccine, I want to see those people not get in line for that. My suspicion is they will. And
well, I'll talk about that if we get a vaccine out. And these are anti-vaxxers that I've heard say, well, I'm not going to have that. I'm not going to have that. And I was like, my thought was, okay, well, then you're choosing to be one of those people that's at risk and possibly get this. And I don't think you should be first in line at the hospital either for treatment. If you're choosing not to take precautions, then, I think you give up some other rights as well.
Well, this is where politically, again, this is where it's going to be, and these are not easy questions, but, it's very easy to mandate school vaccinations and say, if you don't get it, you don't go to school. Okay, then you can do that in court. I know we had it up here in a section of Brooklyn where they were fighting measles vaccination. I get that. Then basically, don't go to public school. I get that. But when this vaccine becomes available, and it is a potentially fatal disease, obviously, and it's going to be an adult population, you can't mandate it for children. There are going to be people who don't want to get it. And there's going to be their conspiracy theory, and it was only the flu to begin with, and all of this sort of stuff. So, you can't force them. number one. And the other question I have is, if you get it, will you need to have that documented someplace before you go to work somewhere? And how are you going to document that? Who's going to track that? What's going to be on your driver's license? How, you want to go get a job in a restaurant or in a big factory, and they say, okay, you gotta show us that. So there has to be some sort of system too for that. So it would be complicated, but not impossible, to vaccinate the country, the adult population, and track that, and hope that the majority of people fall in line.
So let me play devil's advocate for a second here, because I think this is a really interesting part of the debate. For a start, in the UK, it's not legal to mandate a vaccine at the moment. Just so there's a different. We have to kind of draw some conclusions or take note of the different legal framework in different countries. But the argument I've heard, I mean, I was discussing this with a friend who's now a headmaster at a school in the UK, but he's a geneticist by profession, and we were debating the whole social restriction of children coming back to school or staying away, which is kind of a current topic in the UK at the moment. And I think the data at the moment shows that children are not transmitting the disease the same way the adults are, and that's a combination of lower viral load, and they tend to be asymptomatic, so they're not coughing and splushing the vaccine. There's less aerosol transmission occurring anyway because they're less symptomatic. Now, obviously, on the bell curve of infectious more to less, they're down one end of it, but then you've also got to cross-reference that with those people who are more at risk of a higher mortality risk. Now, I suppose the one thing that'd be interesting for me to ask you, Peter, is of the more severe presentations and cases that you see and the higher mortality, are these people who come in with comorbidities? Or, I mean, is there an argument, hypothetically, to say, I mean, let's take me as an example. I perceive myself to be a fit and healthy 40-something-year-old male who's probably at a relatively low risk of mortality. So does that mean that I should have a vaccine, be forced or mandated to take a vaccine, or have my privacy rights trampled in order to have to prove that I've had a vaccine in order to travel or do something, when actually my risk of death is lowish or lower, when actually it's the higher at-risk groups are probably the ones that need the vaccine more than, I mean, you said the fact right now the children wouldn't necessarily be mandated to take the vaccine. Where do you draw the line on the bell curve of, and that becomes a political discussion. And my issue with it is I know anti-vaxxers. I know people who say, I'm in my late 20s, I'm really fit and healthy. My immune system's pretty much firing on all cylinders. So why do I need it? I'll take my chances. Why do I need it? But then that flip side, I also have a friend who died very early on in Belgium, and he was early 30s and fit and healthy. So how can you tell? And it's that, where do you weigh the balance of risk on this versus whether you mandate a vaccine or whether you provide it for at-risk populations?
So, Edward, we've had a surge in the States just very recently in the last week or so, and it's largely the 20 to 30 population, huge younger population. These are healthy people. They're not showing symptoms. They're getting tested at centers. They're coming back positive. And I think that's promoting the spread because they are the healthy people. They look healthy. They act healthy. And so they're carrying this and spreading it. But the surge is with this population. The question, that they're asking now, is it because of fraternity, pledging or sorority pledging or the beach trips and that kind of stuff that all these people are gathering together? But these relatively healthy people could be the carriers, could ultimately be carriers that are just transmitting it to those people that are higher risk.
Yeah, but
that's true. So Edward, you raise a good question. So I guess, when we have this vaccine, we may have to, because of the sheer scope of trying to vaccinate this many people, there might have to be some sort of prioritization. And I can envision where they may say healthcare workers first, as they started to actually do with SARS, okay? Those people who are hands-on working with these patients, healthcare workers first, I can see that. And perhaps the elderly with comorbidity, I can see that. Then where do you draw that line is true. we are seeing, one of my fellows, he lost a classmate of his at 28 last week. Also fit, young, healthy, 28. So there's going to be those outliers out there. 100% agree with you. Their risk is much lower than the 65-year-old with heart disease. Got it. But I guess my answer, I mean, you can't mandate it. I understand that. But I guess if you can try and use a logical argument, and when people are fanatics, logic goes out the window. But if you want to use a logical argument to say the benefit risk ratio is huge, okay? The downside is your personal rights. The upside is maybe you were going to never get it, but now you won't get it. Say we're 100% effective, okay? And there is, to me, an obligation to society, to the world that we live in. And that is, to Chris's point, that you might be 20 and you don't want to get vaccinated, but you've got, 100,000 plaque-forming units of virus in your nose, and you decide to go to the store and buy something and give it to the 50-year-old guy who hasn't been vaccinated, who's bagging your groceries. Yeah, that's irresponsible.
Yeah.
That's irresponsible.
I think my point is it becomes a moral and ethical issue rather than...
Exactly. And those are tough. Those are tough. Just like, we legislated, I know it's different, but, we legislated back in the 80s, if you were a known HIV positive patient and you had unprotected sex, you were liable for assault in the United States.
Yep.
Okay? Now, I'm not advocating we do that here, but at the point of that was that you have some responsibility to the world that you live in. And you're right, there are people who sort of feel, yes, I understand that, but my obligation is low, my risk is low, etc. And I think what you do is you're not going to have an answer for everybody. It's like everything else. You try to have an answer that applies to as many as you can.
Okay, so here's another thought-provoking question then. How do we? I listened, and I'll give you. I'll base it with a story first. I listened to Sir Robert Winston give a keynote presentation at a conference some years ago now, and I found out afterwards he was the worst rated speaker that the conference organizer had ever had. And the reason behind it was that he spoke to a hall full of people of drug development industry, people who worked in drug development. And he said, we've got really bad, and I think it was about the time when, again, it was a kind of anti-vaccine kind of stuff was happening around the now discredited autism-linked the MMR vaccine. And he said, we've got really bad press. Our industry it's perceived as being quite evil and confusing, and he ended it by saying, it's all our fault, it's all your fault. And what he was trying to say and be provocative was, we don't speak about the positives of what we do in our industry very well at all, because we're all a bunch of scientists. We're not PR representatives. We don't work in media. All the good stuff happens, but the media only ever reports the scare stories. So we're in a situation at the moment where the level of trust, and because of the political and media input and environment that's going on around at present as well, we now work in an industry where we're all of us individually are motivated to do well for mankind, but our information isn't trusted by the world at large. So how do we, we obviously bear some responsibility here as individuals and as an industry to kind of somehow come together and rebuild the level of trust in the data, in the practices and the processes. How do we do that? How do we do that for those people? So the anti-vaxxers in Texas or in wherever, who say, there have been so many bloody retractions on the hydrochloroquine studies. You've got Donald Trump saying one thing, Nancy Fauci saying something else, and then the data coming from the UK, and then the Italian doctor saying this, and this is reported there. How do they trust it? How do they trust the source of information?
Yeah, well, see, that's part of the responsibility of things like the WHO, and they have had their issues, to be sure, both on this event and on some other things. But I guess my answer would be, and I'll look at it just from a United States point of view. My answer to that is that you have to put the people out there that know the science and the medicine, okay? Our problem was, I mean, we have a task force that now we don't have anymore. And our task force was typically overrun by political machinery. The task force really needs to be out there front and center, apolitical, and say, okay, here's the data, here's the growth rate, here's what we do. Let's talk about this whole misconception, this gets me, this whole misconception of testing. So much testing, that's why we have so much disease. So totally illogical, but somebody needs to get out and get the message out and explain why more testing will actually make the prevalence of the disease go down. It's counterintuitive, but that's how it works, because then you can contact trace and isolate. So you want to test more, and you want to test more to find your negativity rate as well. People need to get that message out there. The problem is, as you say, these are politically opportune times for whatever side of the aisle anybody stands at. And that's unfortunate. And I wish I had an answer for that, because then I'd run for president.
I think I want to tie it, just kind of close
Peter for president.
Yeah, I want to tie it back to the comment we spoke about earlier about the controversy of whether you give anti-inflammatory steroids early or late. And you've got two camps of people. And again, I'd come back and say, well, there's obviously a disagreement there between two equally valid intellectual medical opinions. And again, that's the kind of where you get the layperson who doesn't work in science, who doesn't necessarily understand that there are two informed bodies of opinion, and they don't reconcile yet. But how do we surely our responsibility lies in actually somehow putting aside our own egos and resolving those controversies so that we can present a unified, reliable source of data to the wider public?
Well, I don't think it's always that easy. I think sometimes scientific data can conflict. We know this, okay? There are often, I mean, in clinical medicine all the time, we don't have all the answers. Sometimes we approximate the best answer and go forward and hope we get the better results. We're making an informed decision, realizing that this may not cover 100% of the issue, but it's going to cover it enough to get us by till we get to the next phase. We grow up with that. We do this. I think we accept that. My counter to that is, and I've told people this, well, this guy is saying one thing and this guy's giving another different opinion, and you guys don't know what you're doing. Okay. I tell people, do you get more than one estimate before you get plumbing done? And do you get two plumbers in there who tell you have two different problems and there's two different ways to solve it? And does that anger you? No. You say, oh, okay, well, I'll pick the one that makes the most sense for me to go with, whether it's cost, inconvenience, time to do the project, okay? That's okay for you. But here we're talking about science and medicine, and we're saying, based in science, there appear to be two different ways to approach this. And we're going to try and find the one that appears by this evidence you have now to be the better one. And we're recommending that, but the other may be equally, maybe as good for different reasons. Just like your plumber who says, both will fix the problem, but you got to decide which one you want to use. People don't get too upset over that, but they want to hold us to a level of, on a complex, ever-changing scientific and medical area, well, tell me what it is, and that's how it goes. It isn't that. And maybe that's how we have to educate them. This is not fixing a pipe, for God's sakes. This is understanding how the body interacts on a virus that, you know, before March, outside of China, nobody heard of this virus. And it's June, and here we are. And you want me to have the one answer, whether you should or shouldn't have steroids, or should or shouldn't have hydroxychloroquine. Okay, we know about that. We know about Lysol. I get all that. But we need to have the answer. It isn't like that. It isn't fixing your pipes.
So, Peter, do you see us functioning 6, 12, 18 months from now back to a normal, the sense of normal we had before this virus, or a new normal? I mean, are we always going to be wearing masks? Are we always, you know, those kinds of things? What do you foresee based on your experiences?
So I see once we have a vaccine, I think that's about when we are able to approach, quote, the old normal, okay? I think once we have that, or we have enough of the population vaccinated, I think we'll start to be able to do that. Until then, I think we're in this for the long haul. And I suspect that even after the vaccine, there will be, and this is okay, there will be a portion of the population who continues to want to wear masks. They should not be ostracized. They should not be criticized. That's fine. I might do it myself. Why not? But that's an individual call. If we get back to normal. Right now, it's mandated, or it should be. When we get back to normal, I don't want somebody to be, having somebody throw eggs at them because they're wearing a mask when we're quote normal. That should be fine. But until I think we get a proper vaccination, or if somebody were to come along and find some other form of treatment is one thing, prophylaxis is another. We don't really have much of anything right now. I think we're in this for the long haul. And 12 months, yeah, I think 12 months, because I don't think you're going to have a vaccine in mass distribution. Just think about what you need for a vaccine in mass distribution. Not only do you need the vaccine, you need syringes, you need vials, you need even the rubber septum that goes on the vials, you need the paperwork. Much of those ancillary things, syringes, vials, septums, are made and imported from China. China's going to want for their country, okay? So the logistics now, unless we start doing things, something like the Defense Protection Act, which we should have been doing, and we mandate companies like Pyrex to start making vials for the vaccine, maybe we can do all that. I like to think all that's going on in the background right now in Washington, and that there are people who are saying, when the vaccine comes, we got a plan, we're going to roll out. That would be great.
I love that optimism.
I have not seen any sign of proactive thinking since March, so I'm not so sure that's going on. But that's what we need, that, we're going to press a button, and we don't want somebody to go, oh, we don't have enough syringes. Well, wouldn't that be absurd? So that, until we sort of have that and that system in place, I suspect distancing, to the extent that people are going to want to keep doing it, and masks and hand washing. Somebody said today, I forgot where it was, I heard that we're sick and tired of the virus, but the virus is not tired of making us sick.
Right.
And this is what we have to remember.
True.
Sorry?
I mean, I think the message that you just gave was a great note to end on, which is we're in this for the long haul. And we need our government to be proactive about being able to administer that vaccine moving forward on a global level.
I think that's key. And between now and then, follow the rules. They're not that hard.
No. It's interesting because having been out to Japan a couple of times, where when it's flu or hay fever season, if you've got it, you wear a mask. You make sure you wear gloves, so you're not transmitting. It's socially irresponsible not to do that.
Correct.
And I think that's probably a standard we could all adhere to in the future.
Again, there are no downsides to it. And maybe it's irritating, but if it becomes part of getting up and brushing your teeth and combing your hair and putting on your mask or putting on your hat, you put on your mask. Yeah. That's it.
Yep. They have some pretty fancy ones nowadays too. I know, Edward, you have some fancy masks, and mine aren't as fancy, but I mean, they can be a fashion statement for us too.
Actually, I know someone in Fargo.
They've been fashionable. What's that?
I know somebody who's making fancy masks in Fargo, actually.
There you go. So Peter, I think we're in it the long haul, guys.
Yeah, no, thank you so much. The information that you have relayed is huge. I think that, I think the more we get the message out and the more we continue to educate people, the better we can get a handle on this. And that's what it takes, is education. It's not about me telling you what to do. It's about me telling you why we need to do things so that people understand and they're more compliant.
That's right. Very well. Well said, Chris.
Darby, Chris and I would like to thank Peter again for being our first guest on the Hat Talks podcast. We hope that the discussion and information is both useful as well as of interest. If you would like to give constructive feedback, suggestions for future topics or guests, please do reach out to any of the three of us. The best place remains LinkedIn.